Uh, so first of all, I would like to welcome everyone to BrainX Community and for this December session. For those who haven't been a part of this, we brought this community together around 5 years ago with the idea of having a platform for machine learning or AI in healthcare for good. Now we have 5,000 plus international member community. The LinkedIn group itself is very active with 2,700 plus members. And of course, we have all the resources available to you for free through our website, brainxai.org. And we do these monthly live sessions so that we have the opportunity to learn from all the different AI community members who are working to integrate AI into healthcare and also have an opportunity to interact with each other. This is the website, has a lot of resources over there. Everything is without a firewall, no login needed. Everything is available for free. This is our update section where you can get the latest information about the upcoming events or anything that is of great interest. We have the Connect segment where we house all the information about our upcoming live events and the recordings from the prior ones. So it has the link to our YouTube channel. And you can subscribe to our YouTube channel directly by the name of BrainX Community and get these recordings directly to your email inbox as soon as they are available. So don't miss out on that and do subscribe us today. As I said, we have a very active LinkedIn group, 2,700 plus members, sharing a lot of scholarly activity, opportunities to meet, opportunities to engage. And we have our Learn section on our website, which provides a curated and filterable list of prominent articles. And one of the articles that is going to be presented today is listed over there. So you can find it over there for your reference. Of course, everybody is looking for open source data sets. So BrainX Community is proud to provide you with the largest repository of links to open source data sets. Of course, we cannot provide you the data directly, but these are the data sets that have minimal DUA requirements as long as you're using it for the right purpose. And you can filter them by topic. So if you're looking for imaging or if you're looking for cardiology or text data, you can find these over here. And you can listen to some of the experts, people who have been researching or trying to implement AI in healthcare through our podcast series called BrainX Talks. And you can subscribe this through your favorite podcast channel, whether it's Spotify, Apple, Google Podcasts. You can get it through any of your favorite ones. So please subscribe us there too and listen to some of the experts from around the world deliver their talks. We would love to meet you in person. So the meetings and conferences are back after the COVID pandemic, and you can find where you want to be or maybe present some of your work or share your work with a wide international community. So you can go over there and find the upcoming meetings and conferences listed over there and directly go to register. With that, again, as I said, alums have caught the imagination of everyone. We have Lavender Jiang from NYU. She's going to talk about NYUtron, a very exciting project. I learned a lot from the publication, but would directly want to learn from her. We also have Aokun Chen, who will join Raghav Awasthi with the panel discussion after Lavender's talk. So with that, I'm going to turn it over to Lavender.
Thank you, Piyush.
I'm just going to stop sharing. Just give me one moment here. All right, over to you.
So, hi everyone. Thanks for the introduction, Piyush. So today I'm here to present our work NYUtron. And the main discovery we found was that we can actually use language models as a all-purpose clinical predictors. This is a joint work between like NVIDIA, led by Anthony Costa, NYU Langone Health, led by my advisor Eric Werman and Indalon, and also from NYU Center for Data Science, led by Kyung Cho. This work is also impossible without my collaborators, and they're listed here. So before I start my talk, I would say that I know that Piyush said that you should like leave the answer in the chat box. But also feel free to make a noise so I can like answer you in real time, because sometimes I feel like when the presentation ends, maybe the momentum is gone. So I'm happy to stop and clear any confusion so that you don't carry the confusion along with you in the presentation. I will also try to make this presentation short to 30 minutes so that we have more time for discussion. Cool. So the plan is that I will first talk about the backgrounds for our work, basically where is Langone, what is EHR, what are clinical notes, and what is the last mile problem that we're trying to solve. In the second part, I will talk about our method, how we pre-train the model, how we fine-tune our model, and how do we evaluate it. And finally, I will talk about some results. Oh, this is our lab mascot called Otto, partially the reason why we're called OLAB. He's very cute. Cool. So let's start with the background. So this is the door I go to work every day. So it's called NYU Langone House. It's this one is the door of the Manhattan campus, but it actually has locations in many different boroughs. So it's a multi-borough health system with a diverse patient population. So the Manhattan campus is here in Midtown East, but we also have like a campus in Brooklyn and also a campus in Long Island. And you can see that according to the census, you can see that compared to the rest of the United States, Manhattan has a more diverse demographic population. Now, what is EHR? So electronic health records is a system that used to document all clinically relevant information. And I'm sure in the BrainX community, there are more people who are aware of it, but in case anyone's not aware of it, here is my EHR as an example. So you can see my picture and my name here. You can see the appointments and visits I had in the past, what medications I'm using and what I used in the past, the messages between me, my primary care doctors, the nurses, and other specialist doctors, and also any test results I have received in the past. So for example, here is a chest x-ray of mine, and you can see that thankfully everything is normal. So this is the source of our data. We use the EHR records from Langone from January 2011 to May 2020. And this covers around 300,000 patients for pre-training and around 400,000 patients for fine-tuning. Specifically in the EHR, the data modality we rely on is clinical notes. And the reason why we choose that is because it's an enriched feature of each patient and case in a unified format. So again, let's look at some concrete example of my notes when I went to the emergency department due to chest pain. So you can see that I'm just like taking a very short excerpt here, but you can already see a lot of information. So for example, you can see my medical history, you can see my vitals, like my blood pressure, my heart rate, and my respiration rates. You can also see the results of my physical exams. So the point of this example is that all information such as lab measurements, treatments, is ultimately integrated into the notes written by the physicians. Apart from this rich information, they also contain physicians' assessment beyond direct measurements and treatment. So for example, sometimes there are information about the social determinant of health, like the patient is homeless, or sometimes we will know like the patient has been abused, so that maybe this case is actually complicated. Now, if you're a data scientist or like a computer scientist or anyone who's data minded, right? You see all this rich data, and it's very natural to think that how can we make use of this data? Maybe we can use them to build predictive models that help the healthcare system to run more efficiently. So people have actually tried to do this in the past, and the results looks good, but they are not widely used in practice. And let's try to go into why. So you can see that when a patient goes to the hospital, their lab measurements, prescription, imaging, and procedures are recorded in the database. And you can think of them as a giant Excel sheet for simplification purpose. And what the traditional model were doing was that they look at this giant Excel sheet, and then they build traditional machine learning models such as gradient boosted tree or just simple logistic regression model based on those structured data. Um, and then they validate the results, and usually it looks good. So basically, it's good up until the modeling part. But the goal of using clinical model in a real environment is you want to close this loop. So this is the red part that I'm highlighting on. Basically, the part where the clinical predictive model takes effect is when the medical professionals see the predictions from the model and then use those predictions for their clinical and operational decision. So this is what we call the last mile. And the problem with previous model was that the last mile was not achieved. So you might ask, why couldn't the medical professionals use those giant Excel sheet based table in practice? So there are actually a lot of reasons, but I will mainly focus on three main reasons. The first reason is that a lot of the times the structured data could be missing. So it's very common to have missing columns. And if your structure model is heavily relying on one feature and that feature goes missing, you can imagine that it's going to hurt the model's performance. Another reason has to do with real-time inference. So at Langone, the hospital's database is updated daily. But usually when the medical professionals need to use those predictions, they need it in real time, and it could be very time sensitive. So for example, let's imagine that you go to the emergency department because you have a chest pain, and the doctors need to use a predictive model for decision making. However, the database is not updated with your complete information until the next day, and it's very hard to imagine that you can wait until then because you have a very urgent problem. A third problem with this giant Excel sheet-based approach is standardization. So because structured data usually comes with unit, it's very common for different institutions or different hospitals to have different units. And so you need to do a lot of normalization and standardization to make sure that your model generalizes to different sites. So for example, let's say that Manhattan uses metric, but Brooklyn uses imperial, then it's not trivial for your model just to directly train in Manhattan and use in Brooklyn. So we saw all these problems with the structured database approach, and our insights for tackling the last mile problem was what we saw previously, right? In fact, a lot of the structured data are captured in the clinical notes. So instead of heavily relying on this giant Excel table of structured data, we can just directly work with the clinical notes. So we saw that clinical notes has a lot of information, and an effective way to work with the text data is language modeling. So we decided to train a language model to read clinical notes. And the reason why we decided to train our model from scratch rather than using an off-the-shelf model is that clinical notes have their own idiosyncrasies, meaning that the medical language is very different than normal languages you see in, say, Reddit or on the internet on average. So if we train our own model from scratch, we can have more efficient tokenizers for understanding the medical language, and maybe we will have fewer out of vocab words. So we train our language model on a large amount of clinical notes from Langone's EHR. And later, if we want to do clinical prediction, we can just fine-tune this pre-trained language model with labeled clinical notes to predict a variety of clinical and operational tasks. So for our pre-training, we have around 7. Oh, I got a question from Danny. He was asking, how did I get access to so many clinical notes? What was the IRB timeline like? so because I'm a PhD student and not a principal investigator, so I don't really take care of IRB. So that question might be better answered with my Professor Eric Orman, but I don't know. Piyush, do you wanna?
Yeah,
Piyush, do you wanna? Yeah.
Lavender, I'll take that. So I think it'll vary from place to place. It depends upon whether they have already curated some of the data or not. All IRBs are different. The way you report to your IRB or you submit to your IRB and how IRB requests further information. So it will vary very significantly. Some IRBs, based on what you submitted, might approve it in few months. Many other places, it might take you a few years to get it reviewed, to get it updated and everything. So I think that's highly variable depending upon the institution and what you submit and the additional information that you might need. And Lavender, maybe we'll just take all the questions together at then. I'm making a note of that so we won't miss anything.
Okay, sure. Thank you, Piyush. Okay, cool. So let's continue. Thank you for the question. So for pre-training, we got around 7 million notes from around 300 patients collected during the span of 10 years. And those includes like medical history and physical, discharge notes, so all types of clinical notes. And in total, it's a corpus of around like more than 4 billion tokens. And so that's for training, and for fine-tuning, we collected data for 5 different tests. Um, 5 different tests. There are 2 clinical tests and 3 operational tests. So for clinical tests, the main goal is to help the physicians with their decision making. So an example test would be we look at the history and physical notes. So when the patient got admitted, and we try to predict how likely would they die in the hospital before discharge. An example of the operational task is to help the administrator run the hospital more efficiently. So an example is we look at the patient's, history and physical notes or discharge notes. History and physical notes, and we try to predict how long would they stay in the hospital. So this will give the administrator a sense of, how long the patients are staying, so that they can better manage admission of patients. So I have description of all the 5 tasks here, and if any of you is interested, we can like discuss them more. But here I will mainly focus on the 30-day all-cause readmission prediction. This is our main task for the paper. So the task is saying that we want to look at the discharge notes and try to predict how likely would the patient come back within 30 days of discharge. So this is we chose this as the main task because it is very well studied in the clinical informatics community. It is a key indicator of the healthcare quality because usually if patients come back prematurely, it could mean that they're not treated well. So we probably should have discharged them, or maybe we should have done something, to prevent this from coming back. Another reason we chose the readmission was that it has a financial significance to the hospital. So I think that for patients with Medicaid or Medicare, if they come back prematurely, there is a large fine for the hospital. So for the 30-day readmission, we have around 400,000 patients, 500,000 notes, and in total around 400 million, almost 500 million words. For each, basically, the data sets have discharge notes paired with a binary label for 30-day all-cause readmission. So basically, we count a patient as readmitted if there was another visit to Langone within 30 days after the discharge date. And this could impact our discharge decision as well as follow-up care plan. So what this means is that, for example, if we see a very, very high-risk patient, the physician can decide to not discharge them, or there are like lower cost intervention we can do to prevent this. For example, we can have nurses to call the patients to make sure they know how to take medications correctly, so that they wouldn't come back, because they forgot to take medications. And before we dive into the exact performance, let's try to get intuitive understanding of why our model is able to predict 30-day remission based on discharge notes. So here is a word cloud. that shows you the signals in the discharge notes. So on the left, you see some words that distinguish non-readmitted patients from readmitted patients, and on the right are some keywords for readmitted patients. So you see that non-readmitted patients have milder disease like pancreatitis. There are some social determinants, like if they have friends who could pick them up upon discharge, then they are less likely to come back. On the other hand, for readmitted patients, they have more serious disease like lymphoma, which is a type of cancers that require regular, follow-up and regular visits for chemo and radiotherapy. So now you see that with the language model approach, we have a unified approach to the last mile problem. So basically, previously we were relying on this giant Excel table. We do the feature selection, and then we try to normalize it, and hopefully the physicians will use them when they practice. But for the language model approach, we don't need to do separate feature engineering for separate tasks. Rather, we just pre-train one language model, and for each downstream task, we just fine-tune the language model based on label clinical notes. So again, here is the illustration. So you see that if you want to predict whether or not I will come back prematurely, you feed my notes to the fine-tuned language model, and then it will output a prediction for either the physician or the administrator for their downstream task. Okay, so we will talk for the specific methods. So I'm going to the methods. Piyush, do you think I should take some questions or answer them at after I finish?
No, I think we'll take them at the end, Lavender. I'm looking through the chat. Yeah, we'll take them at the end.
Okay, thank you. Okay, cool. So the language model we used was a BERT model, and it's not fancy, but BERT just 100 million parameter BERT. The vocab size was around 50,000 tokens, and the maximum sequence length was around 512 tokens. For pre-training, we use NLTK to ensure that sentences are not split across chunks. And then for very long notes, we split them into non-overlapping chunks. So the training objective for BERT was basically mass language modeling. So for example, let's say we have a sentence called Lavender has chest pain, right? So so what this objective was doing is that we will randomly mask out words in the sentence. So let's say, for example, we mask out chest. So then this sentence becomes Lavender has mask pain. And the objective is for the model to fill in the mask word correctly. So in this case, if it could say that mask equals chest, then it will get reward. So we pre-trained our model using 24 A100 GPUs over 3 machines for around 3 weeks and 96 epochs. We trained until the validation loss started plateauing. For optimizer, we use zero redundancy weighted atom optimizer with a constant learning rate. And we also use floating point 16 mixed precision and stage 2 parallelization to speed up our pre-training. For fine-tuning, so basically after we do the mass language modeling with our BERT model, we attach a randomly initialized linear classifier at the end of our model for each different task. And then we just fine-tune our model end to end. So we didn't do anything fancy or novel here. We just follow what BERT and Roberta did in their paper. And for deployment, so we specifically did a silent deployment from January to April of 2022 to basically test our model in the wild, but it was a silent deployment without intervention, so that we make sure that if the model is not good, we won't actually be harming the patients. And during this 4 months period, there were around 29,000 discharge encounters. And among those encounters, around 3,000 patients came back prematurely. And we asked a panel of physicians to analyze analyzed those readmissions, and we saw that among the unplanned readmissions, around 20% of them experienced an adverse event or death on the readmission. And the panel of physicians also thought that 50% of those, unplanned readmissions with adverse events was actually preventable. So during the inference time, here's a figure illustrating what we did. Whenever a doctor finishes typing a discharge note, it gets sent to our database. So then this database would connect to our inference server. So then our inference neutron will be able to read the discharge note and output a prediction. In this case, it's like a probability between 0 and 1 that indicates the risk of readmission. And then for very high risk readmission cases, our inference server will send an email. If we want to really close the loop, right, with intervention, we want to send it to the physician who was writing the notes. But because we're doing silent deployment, the prediction was actually sent to our development team. So it's me, Eric, and like maybe 2 other physicians. So this is the silent deployment that we did. And that was counted as so basically we have 4 types of evaluation, and the silent deployment was actually just one of them. And the silent deployment is a prospective observational deployment. So basically we deploy in the wild and test it on the fly daily. So this sort of test cannot cheat it because we cannot look at the data and then tune our model to kind of hack the metric. This was done after we finished developing our model. During developing the model, we have 2 other types of evaluation. So the most simple types of evaluation is retrospective evaluation. So basically during this time period, January 2013 to May 2021, we did a train, validation, and test split. So basically a traditional threefold split that just randomly split the models. So this was one of the evaluation we did during development. Another thing we did to account for the temporal shift or the distribution shift over time was a temporal evaluation. So basically you saw that previously the 3 splits were all from January 2013 to May 2021, but during development we also blocked out 3 months, that is June 2021 to December 2021, to see if we train the model in the past, basically from the random split, and we test it in the future, basically test it on the temporal split, will the model still perform well? And you see that this is a more difficult test, right? Because the readmission rate could change over time. There might be surprise events like COVID that happens. So in general, temporal test is a harder test than the random test. So basically during development, we did both the random test and temporal test. After we're confident with the results, we did this prospective observational evaluation. And eventually the eventual test we want to do is to do a prospective interventional evaluation. And this has not been done yet because we still need to think about how to design an effective and safe interventional strategy. So what it would look like is if the model's prediction passes the threshold, then we would do some intervention. For example, preventing the patient from being discharged, or ask nurses to call the patients after they discharge. And we can compare, for example, using A/B testing, compare if using intervention will reduce the readmission rates. So that's part 2 of our method. Is it okay if I go to the results? Cool. So I have a lot of results, and I think I'll just focus on some key results here, and then if there are more interest, we can talk about them more in the Q&A. So the first first finding we have is temporal split is like much harder than random split. And if you just use random split to evaluate your model, it will overestimate the accuracy significantly. So again, for the temporal test, you train in the past and test in the future. But for random tests, you train, validation, and test in the same time period. So this is here you have two very complicated plots. Let's first not worry about what like each color of the line means, but just look at the general trend. So on the left is the model's AUC. So the x-axis is the number of training examples. So you see one trend that basically when you have more training examples, the performance becomes better, and that's intuitive. And on the right, so the left versus right is random test versus temporal test. You see that on the left, the curves are generally higher than the curves on the right. So this means that the random test performance or the same time test performance is generally higher than the temporal test performance using the same model. So this shows that it's important to use temporal tests to evaluate model performance during the development phase, because it more closely mimics the deployment scenario where you train using data from the past but then test in the future. So it's important to account for the temporal shift when you try to test your model. Another finding, evaluation we did was we did a head-to-head comparison between NYUtron and 6 physicians. So they were all physicians at Langone, and they have different levels of seniority. I gave them 100 discharge notes and asked them to predict whether or not the patient will come back. But because they were really busy, so they only did 20. The readmission label for those 20 notes were pretty balanced, like around 11 readmitted notes and 9 non-readmitted notes. And then we compare the true positive rates and the false positive rates of the physicians and the NYUtron. So you can see that the green circles are physicians, like each individual physicians, there are 6 of them. The orange triangle is NYUtron, and the blue triangle is the median physician performance. So you see that NYUtron has the same false positive rates as a median physician, but then it has a higher true positive rate than the median physicians. However, it's still worse than the best physicians, which is this green dot here. We also did a comparison between NYUtron's approach, which is the language model approach to clinical prediction, versus the traditional approach that we discussed, basically the one that based on giant Excel sheet, and we call them structured data baseline. So for the structured data baseline, we select features based on the literature, and then we use those features to train gradient boosted trees. So what we observed was that NYUtron plus clinical nodes outperform the structured data baseline in all 5 tests. So here are 2 comparisons on the in-hospital mortality prediction and the readmission prediction. The green bar is NYUtron, and the gray bar is the traditional baseline. And you see that for those 2 tests, there is a margin between the green bar and the gray bar. So apart from the benefits of better accuracy, now we also have a unified representation, which is the medical language. This means that we don't need to do meticulous feature engineering for each particular task, but rather we can just fine-tune a pre-trained language model with labeled clinical notes. We also see that the amount of label, when you're choosing between clinical notes and structured data, the amount of label data you have actually matters. So this is the temporal test AUC for readmission prediction. So you see that when we only have 100 fine-tuning examples, NYUtron is the green bar, and then the traditional baseline, which is gradient boosted tree using the LACE features, is the yellow bar. You see that actually they are pretty inconclusive, right? It's not clear which one is better than which because the variance is pretty large. But LACE actually has a higher median than NYUtron. So it's fair to say that when you have very, very limited examples, around 100 fine-tuning label examples, NYUtron is not necessarily better than the structured baseline. However, neutron scales better than the structure baseline as you have more fine-tuning example. So you see that when we have 1,000 fine-tuning examples, neutron caught up to the green bar caught up to the yellow bar, and in fact it has a little bit higher median. When you have 10,000, the gap became larger. When you have 100,000 examples, the gap became even larger. So basically, you see that as we have increasing number of fine-tuning examples, neutron continue to benefit from this increased number of examples, whereas the structure baseline kind of just started plateauing. So this is why their performance gap became larger and larger as you have more fine-tuning examples. Apart from the data, the amount of label data is important, and the domain of your pre-training data also matters. So in this comparison, you see a lot of different color bars, right? And their name, they all have different types of pre-training purpose. So basically, there are a mix of clinical text, which is clinical notes, biomedical text, mostly scientific articles in biology and medicines, and general text, that is web pages and Wikipedia. So let's compare them. So you see that for Neutron, which is ours, it only uses clinical notes. So it has around 4 billion real clinical notes. So this one, web wiki plus bio plus clinical, is the 445 million parameter Gatortron. So it's called this because it has, web wiki, which is the general text, around 2.5 billion. The biomedical text around 6 billion, and also clinical text around 82 billion real clinical notes from University of Florida. And then the next one is BioBird, which doesn't have the clinical aspect, but only web wiki and bio, and also the original bird base, which has only seen web text. We also control for no pre-training. Let's just use a randomly initialized BERT model and see what will happen. So for the random init model, it has not seen any types of text. And let's compare them on the I2B2 2012 clinical concept extraction test. So you see that when your model has not seen any data, it's just worse. So this light green bar is the random init that has the worst performance. And then after, if you give it some web text, it becomes better. So it's the pink bar here. If you also additionally incorporate biology papers, it becomes even better. If you additionally incorporate clinical text, it becomes even better because after all, we're doing clinical concept extraction. And so here the green is neutron and the orange is Gatortron. You see that over here, the green neutron is actually slightly worse than Gatortron. And our hypothesis is that for this test, the I2B2 2012, the data actually comes from a Boston hospital. And a Boston hospital, I think it's the same one as Mimic, where the Mimic comes from. And Gatortron actually has seen some Mimic nodes during its pre-training, whereas Neutron has not seen Mimic nodes during pre-training. So although they are similar, Neutron is slightly worse, right? And it's possible that the clinical nodes from NYU is slightly different than the one from I2B2. And having seen those types of data could help Gatortron on this I2B2 NER test. We also see that apart from the pre-training data, fine-tuning domain also matters. So we did a control study where, for example, we pre-train in Manhattan, we fine-tune in Brooklyn, and we test in Brooklyn, versus we, doing everything in Brooklyn. So you see that the demographic distribution in Manhattan and Brooklyn are quite different. Specifically, Brooklyn is more diverse than Manhattan. And the main finding we have is that it's okay if you're so the main finding we have is that it's best if you do everything locally. So when you want to deploy in Brooklyn, right? When you deploy in Brooklyn, it's best if you local fine tune in Brooklyn. But if you but let's imagine that Brooklyn is a very small hospital and they don't have enough data to pre-train their own language model. So could they use a pre-trained language model from Manhattan and just fine-tune locally? Would it work as well? And what we found is that yes, it's okay. So as long as you have enough fine-tuning data, it's okay if you pre-train in Manhattan and test in Brooklyn, right? The performance is actually similar to pre-training in Brooklyn and testing in Brooklyn. But if you have, but it's always better to have more pre-training data, because if you mix more data in your pre-training and assume they are similar, it's going to help with your downstream test. So I think I have more results, but I think I want to leave more time for discussion. So is it okay if we start taking questions, Piyush?
Yeah, no, this has been like very exciting, and there has been
Yeah.
so much going on in the chat, both technical and on the implementation side. So I think I'll go through some of those questions, but I do want to invite Aokun Chen too to join us, and Raghav Awasthi to join us, because I think getting a diverse set of experience and responses over here might help respond to some of these questions too. So Lavender, I'll share some of the questions across the panelists over here too, if you don't mind. I think there was a question initially, a technical one, which was related to the clinical notes, came from Wei Wei over here, and it was about the mean average. Uh, so let me just read it. I'm not sure if I'm interpreting it right way. Does that mean, I think I'm trying to correct it a little bit. Does that mean on average you have got a little more than one note for each patient? So when you trained it
Yes.
based on the data that you had, is that what it means?
You mean pre-training? Is
Yeah,
that
I think it's for pre-training. My guess is it's for
yeah.
pre-training.
Yeah, so it's normal for, so it's not uncommon for patients to have come here at least twice during 10 years. It's also not uncommon for a patient to get more than one note during one encounter, because they could get a admission note and a discharge note and maybe a progress note in between.
Yeah, okay. And
Yeah.
that's very common. We see like in Mimic data set that there are a lot of discharge summaries, and then there might be 1 to 2 or more inpatient notes. That's in the Mimic data set that comes from Beth Israel. Aokun, what's been your experience with this? Like, what was the average number of clinical notes that you found in Gatortron when you were training
Uh,
Gatortron?
yeah, well, I actually didn't really have I didn't have like a me to really check on like how many how many nodes we have for each patient.
Yeah.
But what I did saw is was what some current projects when I was using some I would say some notes from like the cancer patients. Well, if we remove those, I would say really duplicated notes, since some notes could be like just around like 1 day and second day, and they're basically have very similar descriptions in there. I think for that we are possibly getting. I would say if the low numbers should match as what Lavender found is like 1 to 2, but we do have those like very strange patients that has been with the hospital for a long time that has like tens or maybe some extreme cases like hundreds of clinical notes of different type. But I'm not sure if Lavender has like the team has also select some specific type of notes, because we also find like there are many like I'll say letters, I'll say what a telehealth or even some phone call notes that really serves no purpose in the I mean in like in using that as a either I will say for any kind of substream task or what has mentioned like the last mouse gaps or even or to train the model. So I will say this numbers is I will say for most cases matches what we saw on our side.
Got it. There's another question over here, comes from Subrato, which is about which LLM model was used for fine tuning. I did respond to that from what I interpreted. You pre-trained your model, right? So it's not like you took
Yes,
any large language model. You pre-trained your own model. And I
yes.
think in terms of NYUtron also, they pre-trained their own model, and then they fine-tuned it for a particular task. So it's different from what we are seeing these days, where there are all these large language models which have been made open source, thankfully and gratefully, and you can then fine-tune it further on your own data if you need to, or look at their performance and see if you, for a defined task, you need to. What are your thoughts on that? Because I had the same question, that is it better to take some of the high performing LLMs that are open source and then just fine tune it using your data rather than trying to pre-train from scratch? What are your thoughts, Lavender, on that?
Ah, that's a good point. So actually, a experiment we wanted to do, like after GPT came out, was we just want to ask GPT the same questions here, right? But the challenge we had back then was like we couldn't do this because of HIPAA. Like we basically don't want OpenAI to see all our patient data. So recently we got access to our on-prem GPT, and that's something we can test on. But I think like a group from MIT have studied this, and they published a paper called "Do we still need clinical language model?" Let me type it in the chat. Language models, and they basically compare general language model with their own like pre-trained T5, which is much smaller. And their main finding was that domain specific model was still, like, even when smaller, is still larger, better on like specific tasks than the general like monolithic large model.
Raghav, what do you think? We've been trying to experiment that on BrainX AI research side too, to see what approach to take. What are your thoughts on that?
I think it's
My
like
thoughts?
yeah,
Sorry.
sorry, Lavender, go ahead.
Yeah. No, I thought it's to me, but yeah, I understand it's a question towards you. Go ahead.
Okay, yeah. So, according to my experience, the good thing is to start with the high performance model, uh, and then experiment on the, because this performance depends on the data to data. So we cannot always say that if this particular model is performing well on this data, then it will perform well on another data. So because the purpose of these pre-trained model is to providing a generalizable solutions. So I think we should start with uh, the available high performing model, then we can go more into other models.
Yeah, I think it also depends upon what they've been trained on, right? So the EHR data is very unique in its architecture. Aokun, what do you think about this? Because the architecture of EHR data and what it contains, I don't will find that kind of data or that quality of data in any general source. So what do you think from your experience with NYUtron? Would you pre-train everything again, or would you take a large language model that is available out there, high performing, multi-billion parameters, and then try to fine-tune it for your purpose?
Well, I can actually share some experience when we have another training project, when we take a large, really like pre-trained, or I'll say tuned large language models, and we wanted to like further training. It's not p-tuning, it's like continue training that with I'll say some of the clinical notes. I think though that time that project was using the mimic notes, and we find a thing is that actually during the very first like few phase of the training, the performance of the model actually will drop. So what I would like to say as I'll say as my perspective is, if you are, I would say, if you are aiming, if you like, it really depends on how much of the training data or to say the clinical notes you have. So that case is if you have really scarce clinical notes, I don't think something like training a new model, or even continue training from a large language model will really work in this case, since it's really like instead of like having the model converge on a new, I'll say, consensus or a new set of features, it will actually confuse the original pre-trained model. But another case is if you have already have some amount of data, especially I'll say mimic, that will start to give you some unique privilege that you have with the clinical notes. And that's where we start to say, like, after a few epochs, the model starts to perform better than the original trained large language model. But if you really have a huge amount of clinical notes, especially you're backed up by hospital, that's really to really pre-training or continue training or even training a new large language model really shines, which will give you the best results and will also fit into your very specific clinical notes, since we, not only Lavender, but also us find that even within using the same EHR systems, the clinical notes could be really different. So
Yeah.
that's probably my perspective on this.
No, I think that's a great perspective. You're right. It kind of depends upon how much data you have too, and how you approach it. But there was a related question over there too. So, a lot what we talked about and what we talked about even in Gatortron was based on clinical notes. But there was a question in the chat about what about adding additional data? So there is only so much information that is there in clinical notes. But prior to all the large language models, we were seeing a lot of predictive models being based on a lot of additional data that exists over there. And probably you could use that too, as has been used in the past. So will that be complementary? Does that become just, is it just additive, or it's not as useful anymore? So how do you approach that? Just taking clinical notes versus taking clinical notes plus a lot of additional information. So Lavender, I see you have some thoughts on that here.
Oh no, I changed the slides because I want to like match the slides with your discussion topics, because
Yeah.
I think this plot
No, that's
shows
great.
like different, yeah. Yeah, but I think if you want to take other types of information, then I think it's not just language modeling, right? It becomes like multimodal.
Yeah.
And I think if you have enough data and you do the optimization well, like if you train the multimodal model well, it's definitely going to be better. But I think the challenge here is that sometimes you don't have enough like multimodal data, like some modes might be missing, or that it's because your model becomes larger, it's like more difficult to train it well. And I think it will be especially useful if like you can trust the radiologist reading, right? Because in the notes, the radiology do say that the brain looks normal or not normal. And the benefits you could have from adding image in this case is that if the radiologist was wrong and your image model is able to catch that, then it would be better. So basically, I think it's going to be helpful when there's an error in the text data.
Yeah, also the question of redundancy. So say when you look at the discharge summaries, sometimes there are the medications that are already there in the medications list that were given to the patient. They go onto the discharge summary that these are the medications that the patient received during the admission. And also there is a lot of redundancy too. So does that create additional bias? Aokun, what do you think? Like if you were to add this, is it complementary, or does that just add to a lot more noise and it's harder to deal?
I would say that reaches a questions that we are also experiencing now on our side is actually what is the ideal ratio of mixing these data. So actually this, I would say this number is really different from even from time to time and also from models to models. So so I think one of the things I can say is that because we're now training a new, not really now, where some other groups is training a new models, and they ask us like if we can share with them what is the training ratios we have for especially for Gatortron. And we said for Bird Gatortron we're using almost like 9:1 ratio for the clinical notes to to the general context. And what they told us is like this kind of ratio might not work on on their model. And this is something that's started to become really crucial in the I'll say in the model training. So it's really hard. I'll say there's a paper with some consensus, like you got a 5-to-1 ratios between the between the clinical narratives and the general texts. But I would say there is really no golden answers here on that. Like, what are the ratios that you should mix mix the clinical notes and I'll say the general text. But for us as cases, well, general text do helps a little bit, especially when you have very limited clinical notes. It will help the model to really understand the semantics. And also, if you continue training from a already trained model, that will do help the model to like get out of the initial pit where the previously learned parameters are updated and some of the important knowledge has been lost from that model.
Yeah, I think especially with all these new multimodal models being proposed out there, you saw the one from Google Health being proposed. I think it's going to be an interesting challenge to see how we use these different types of data and how do they fit into the model, and then how do they perform for different tasks. I think it will be very interesting as this gets more complicated next year. But Lavender, I do see another technical question in the chat, and I think you did explain it a little bit in your presentation too, that how did you decide on the 96 epochs and the 3 weeks run? Of course, that was partly based on the computation power that you're using, but how did you pick up the training parameters for like how many epochs you wanted to run? Sorry, Lavender, you're on mute there.
Oh, I'm sorry. I was yeah. Okay, sorry. So basically, originally we picked 100 epochs, and we thought, okay, we just like do it, and then it's not like if the loss was still decreasing, then we like continue to train it. But like around 96, it already looks pretty flat. So we just decided, okay, if we continue it, it's gonna be not different. So we just stop. Does that answer your
Yeah, I think that does answer the question. But there's another interesting question that was there, which was related to the the focus of the data. So you're predicting readmission, and amongst all the text, and Raghav has done a lot of research work in this. So Raghav, I'll ask you first. What about the social determinants of health? How would you weigh those different from like say just the clinical notes or discharge summary for a particular given task? Like how would you approach that? So clearly to a lot of us, based on prior healthcare research, social determinants of health would weigh very heavily in determining readmission. And social determinants of health, for those who don't know, well, are things like the financial situation of the patient, the family structure, the nutrition and things like that. So what are your thoughts about how do you weigh these things in for a given task?
Yeah, so actually it will depends on what disease we are tackling with. For example, if we are tackling with the disease like diabetes or some diseases which are associated with the obesity, then I think we know that the social determinants of play a significant role. But for many diseases, we don't know how much social determinants of play, what factor they play. So it will depend on disease to disease, I think.
Lavender, what do you think? How did you approach that?
incorporating social determinants of health?
Yeah.
Yeah, I think it's definitely gonna be helpful. I think a lot of the times, if the physician thinks that that's important, they will probably like leave it in the notes. But if you want to like explicitly force that to be in your data, you can probably just, for example, add a sentence at the beginning, based on your like some sort of data query.
All right, I think we largely covered most of the large language model questions. I'm going to leave the last few words. Lavender, what are you excited about for next year? What are your plans with large language models and your research work?
I'm really excited to see, like, to evaluate its clinical impact in the interventional trial, to see with intervention would see, for example, improve the quality of healthcare. I'm also excited to see some like human computer interactions research, like basically if you actually have physicians interact with it, what's the optimal way to interact with us such that they are not negatively affected by like what the model says, right? I'm also excited about retrieval-based model. Like basically maybe when we do generation, we can condition on the patient's history, and then maybe we can ask the model to actually look into the hospital's database to retrieve relevant information. So I think that will improve the factuality and also improve the interpretability.
That's great. Aokun, what are you excited about, and what are you looking forward to next year, 2024?
Well, as one, I would say, as one side, it's always the stories. It's like you have a very great models, you have very great things, how that will benefit the patients, how it will benefit the medical area. That will be definitely some I will say very important aspects for the research that we were starting to looking at. And also on this side, I think we will because since there's lots of new models coming out these days. I think another thing is also to explore how the new models will be able to do compared with the old BERT or old I'll say GPT models. Yeah, and also another thing that also excited everybody is about the multi-model things. Like we got images, we got that already existing there structured electronic health data. And we got this unstructured health data with clinical notes. And also maybe there's a genetic data and how we could combine these together, and then how we could make a difference by using a combine of these to really have a multi-model thing that's probably solving everything or even replace part of the jobs of the clinicians. Maybe that's too bold to say for now.
Raghav, what about you? What are you excited about with the large language models in 2024?
Yeah, so I'm more excited about the evaluation part. So because these large language models are proposed, so there are no gold standard method to evaluate them. For example, we don't have any good solution how to evaluate the hallucination and how to evaluate them in a different task. Like we don't know how much these models are generalizable into different healthcare side or another different field like finance. So I'm more interested into how to evaluate these models.
Well, that's great. I think thank you, Lavender, for an exciting talk. Thank you, Raghav, and thank you, Aokun, for following up with a great panel discussion. I think it's beyond time, so we will end this for now, but we'll be happy to carry on the conversation on BrainX Community on the LinkedIn group. So if you have further questions, put your questions in there in the LinkedIn group. We'll be happy to follow up on that, and looking forward to a very exciting 2024. So thank you all.